First, we will take into consideration the superficial structures of the lower limb. When it comes to the nerves, there are many cutaneous nerves that supply the skin of the lower limb. But only some of these cutaneous are important and the students should remember. Now the lateral cutaneous nerve of the thigh, or the lateral femoral cutaneous nerve, is important because this nerve can get entrapped underneath the inguinal ligament when it travels under the inguinal ligament on its lateral part. The condition caused by this compression is called meralgia paresthetica, or Bernard-Rutt syndrome sometimes. Now, due to the entrapment of this nerve, the patient can get tingling sensations or numbness or burning pain on the anterolateral aspect of the thigh, the area supplied by the lateral femoral cutaneous nerve. This condition can be treated medically with drugs given orally to the patients, and if it does not respond to drugs, a surgeon can go in and release the nerve under the inguinal ligament. Next, we will take a look at the structures that are related to the medial malleolus and the lateral malleolus. First, if you take the medial malleolus, saphenous nerve and the greater saphenous vein are related to the medial malleolus anteriorly, and the posterior arch vein, which is an important tributary of the great saphenous vein, is related to the medial malleolus posteriorly. When it comes to the lateral malleolus, superficial peroneal nerve and the branches of the superficial peroneal nerve are related to it anteriorly, and the small saphenous vein and the sural nerve are related to it posteriorly. Here you can see the great saphenous vein and the saphenous nerve. You can see the saphenous nerve drawn in this green line is related to the great saphenous vein anteriorly, and both are anterior to the medial malleolus. Now this is the lateral malleolus. You can see the branches of the superficial peroneal nerve related to the lateral malleolus anteriorly, and the sural nerve related to the lateral malleolus posteriorly. In this diagram, small saphenous vein is not seen. Now there are four important tributaries of the great saphenous vein that open into the great saphenous vein very close to the saphenofemoral junction, where the great saphenous vein enters the femoral vein after passing through the saphenous opening of the fascia lata. You can see there is one vein coming from the lateral aspect of the thigh and the trunk, which is called the superficial circumflex iliac vein, and from the medial side of the anterior abdominal bone below the umbilical area is drained by superficial epigastric vein, and there are two veins draining the medial aspect of the thigh and the perineum. They are superficial and deep external pudendal veins. Another important tributary of the great saphenous vein is the posterior arch vein, which is related to the medial malleolus, as I said before, posteriorly. Now we will take a look at the deep veins of the lower limb. The first point is the deep veins follow arteries. Now what are the arteries you get in the lower limb? External iliac artery becomes femoral artery and enters the lower limb below the inguinal ligament. Now the femoral artery becomes popliteal artery at the adductor hiatus, and the popliteal artery extends from the adductor hiatus to the soleal arch. At the soleal arch, popliteal artery divides into an anterior tibial artery and a posterior tibial artery. The posterior tibial artery gives a branch which is called the peroneal artery. Anterior tibial artery supplies the anterior compartment of the thigh. Posterior tibial artery supplies the posterior compartment of the thigh. while the peroneal artery supplies the peroneal compartment or the lateral compartment of the thigh while being inside the posterior compartment together with the posterior tibial artery. As I said before, deep veins follow arteries. Therefore, you have a posterior tibial vein and an anterior tibial vein joining and forming a popliteal vein at the popliteal fossa, and the popliteal vein becomes femoral vein at the adductor hiatus. There is a peroneal vein opening into the posterior tibial vein. If you draw the superficial veins and the deep veins together, this is the picture you get. You get great saphenous vein starting from the dorsal venous arch, traveling on the medial aspect of the leg and the thigh, and entering the femoral vein in the upper end of the thigh after passing through the saphenous opening of the fascia lata. And the small saphenous vein again enters from the lateral aspect of the dorsal venous arch, travels on the posterior aspect of the leg, pierces the deep fascia at the popliteal fossa and enters the popliteal vein there. The posterior arch vein enters the great saphenous vein, and we have already discussed the deep arteries, deep veins in the leg. Now there are connections between the superficial veins and deep veins of the leg and the thigh. Now these veins that connect superficial veins to deep veins are called perforating veins. There is a perforator above the knee joint which connects the great saphenous vein to the femoral vein at the lower end of the adductor canal. Therefore, it is called adductor canal perforator. Then there is another perforator joining the great saphenous vein, or sometimes the posterior arch vein, to the posterior tibial vein. This is called below knee perforator because it lies about hand's breadth below the knee joint. Then there is a lateral perforator, which is the only lateral perforator, which joins the small saphenous vein to the peroneal vein. Then there are three medial perforators. The upper medial perforator connects the posterior arch vein to the posterior tibial vein. Both the lateral perforator and the upper medial perforator, they lie at the junction between the lower third and the middle third of the leg. Then there is a middle medial perforator which lies immediately above the medial malleolus, and a lower medial perforator which lies immediately below the medial malleolus. The function of the perforators or perforating veins is to connect the superficial veins to deep veins. There are valves in the perforating veins that are directed towards the deep veins, and the deep veins are situated surrounding the arteries inside bulky muscles of the leg. Now you get these veins inside the soleus, and those are that is called soleal pump. When the soleal muscles contract, the deep veins are squeezed, and there are valves inside the deep veins directed towards the heart. Blood is inside the deep veins is pushed towards the heart, and when the muscles relax, the pressure inside the deep veins drop, and the blood from the superficial veins are sucked into the deep veins through the valves in the perforators. And when the muscles contract here, as I said before, when the pressure rises here inside the deep veins, the valves in the perforators close and prevent blood regurgitating back into the superficial veins. Sometimes these valves inside these perforators can become defective. When you call incompetent valves. And when there are incompetent valves in the perforators, when the muscles of the lower limbs, especially the soleus muscle, when it contracts, blood in the deep veins is pushed towards the superficial veins, and then the pressure inside the superficial veins increase, and the blood gets collected in the superficial veins, and that can give rise to elongated, tortuous superficial veins, which are called varicose veins. In this slide, you can see a description about each of the perforators that I mentioned previously: the adductor canal perforator, below knee perforator, lateral perforator, and upper, middle, and lower medial perforators. As medical students, you need not know the exact positions of these perforators, but have a rough idea that there are perforators between superficial and deep veins, and the issues related to defective valves in the perforators. Now there is a condition called deep vein thrombosis. The passengers who are traveling for long distances, not moving their limbs, not contracting muscles of their lower limb, they can actually get blood clots developing in their deep vein system, which is called deep vein thrombosis. And if you travel for long distance in flights, you know that you're advised to contract your muscles, lower limb muscles, from time to time to prevent this condition. Now this deep vein thrombi can get dislodged, they can get separated from the wall of the vein, and they can pass directly through the heart into the lungs, causing what is called pulmonary embolism, which is a life-threatening condition. Remember this point also. This is a picture to show you the deep vein thrombosis. Here you can see this right leg of this patient is swollen, red, compared to the left leg. Now this person is having deep vein thrombosis. If you look inside the veins, you will see something like this, a blood clot inside the deep veins, and the third picture shows part of the clot broken and passing through the blood towards the heart, which is called embolism. Now the varicose veins, when you start doing your surgical appointment, you will see many patients with varicose veins. They are defined as dilated, elongated, and tortuous veins of the lower limb. You can see in this diagram the situation in a normal person, where the valves in the superficial veins directed towards the heart prevents backflow of blood. Now in this condition, varicose veins, the valves are defective, therefore blood flows backwards and gets collected inside the veins, elongating them, dilating them, and making them tortuous. You can see here a normal vein and a varicose vein. It's elongated, dilated, and tortuous. If you are asked to define a varicose vein, you need to use these three terms in your definition. Now in this patient, you can see there is varicosity of the distribution of the great saphenous vein on the medial aspect of the thigh, and here also you see a great saphenous vein varicosity. Now in this case, third picture, you see varicose veins of the small saphenous vein. We will discuss saphenous vein cutdown at the ankle. Now when there are conditions where patients have low blood pressure due to blood loss or volume loss, it is almost impossible to catch veins in the other areas of the body, especially in the upper limb. Now in such conditions, it is important to find out the great saphenous vein in relation to the medial malleolus, in front of the medial malleolus, and use it as a venous access. Now this happens in patients, burnt patients, and maybe after road traffic accidents and loss of blood, lot of blood, and in such conditions, what you do is great saphenous vein cut down in front of the medial malleolus, where you give a local anesthetic agent to block the branches of the saphenous nerve which supplies that area, and then you put a transverse incision in front of the medial malleolus, identify the saphenous nerve and the great saphenous vein, and you prevent damage to the saphenous nerve, and you enter the great saphenous vein with the cannula, and you suture and close it up, and then you can use it as an IV access to give saline or other fluids. Saphenous vein can be also accessed at the groin, where it opens the femoral vein, and to open up, you have to give local anesthesia here. There actually you are blocking the branches of the ilioinguinal nerve and the intermediate cutaneous nerve of the thigh. Then there's a transverse incision put by you 2 finger breadths below and lateral to the pubic tubercle, where the great saphenous vein drains into the femoral vein. You put your cannula. Few points about fascia lata. Now the fascia lata, if someone says the attachments of fascia lata is attached from the pubic tubercle along the inguinal ligament and the outer lip of the iliac crest, and then it is attached to the sacrum and the sacrotuberous ligaments, ischial tuberosity and ischiopubic ramus here. Then on the anterior side, before that actually it splits to enclose 2 muscles, tensor fasciae latae in front and behind gluteus maximus. Then after getting attached to the ischial tuberosity and the ischiopubic ramus, it is attached to the body of the pubis, and it is attached along the pectoneal line, and you can see an overlap of the 2 edges of the fascia lata here, and this overlap actually creates the saphenous opening. Now on the lateral aspect of the fascia lata, there is a thickening which is called iliotibial tract. Now we discussed about this iliotibial tract in our previous lectures, and we said that the 2 muscles enclosed by fascia lata, the tensor fasciae latae and gluteus maximus, are actually attached to the tensor fasciae to attach to the iliotibial tract here. And the distal attachment of the iliotibial tract is to the lateral condyle of the tibia here, and the function of the iliotibial tract is actually the lateral. It stabilizes the knee joint laterally, as well as it maintains the knee joint in hyperextension. And we discussed the locking and unlocking mechanisms of the knee joint in our previous lectures, and we said when you hyperextend the knee joint, the femur rotates medially on the knee joint, and then all the ligaments in the knee joint and in and around the knee joint get tightened, and then you call the knee joint is locked. And when you want to flex the knee joint from that position, you have to unlock the knee joint, and that unlocking is done by the contraction of the popliteus muscle, which is a muscle of the posterior compartment of the leg, a deep muscle in the posterior compartment of the leg, which is attached to the lateral condyle of the femur. When the muscle contracts, the femur rotates laterally, and then it gets unlocked. The knee joint gets unlocked, and from that position you can flex the knee joint. If we look at the motor nerve territories of the leg, again we have discussed this point in one of the previous lectures. Now there are 3 components of the thigh. You have an anterior compartment, you have a medial compartment and a posterior compartment. The anterior compartment of the thigh is supplied by the branches of the femoral nerve, and the medial compartment is supplied by the branches of the obturator nerve, and the posterior compartment of the thigh is supplied by the sciatic nerve. Now we said the sciatic nerve has two parts. Actually it has two components. It has got a tibial component and a peroneal component. It is the tibial component that supplies the posterior compartment muscles of the thigh, and these muscles are called hamstring muscles, and together with the other hamstring muscles, the posterior part of the adductor magnus also operates as a hamstring muscle, and that part of the adductor magnus is also supplied by the tibial component of the sciatic nerve. The rest of the adductor muscles, including the anterior part of the adductor magnus muscle, adductor longus, adductor brevis, and gracilis, they are all supplied by the anterior and posterior divisions of the obturator nerve. Now, the obturator nerve, as we have discussed before, it is formed by the anterior divisions of the lumbar spinal nerves, second, third, and fourth lumbar spinal nerves, and the femoral nerve is formed by the posterior divisions of the second, third, and fourth lumbar nerves. Therefore, both nerves, the obturator nerve and the femoral nerve, have similar segments, lumbar 2, 3, and 4 segments. Few points about the femoral sheath. Again, we have discussed this in one of the previous lectures. We said that the femoral sheath is a continuation of transversalis fascia of the abdomen and iliacus fascia lying on the muscles of the iliac fossa, and the femoral sheath actually extends about 1 inch below the inguinal ligament, and it encloses the femoral artery and the femoral vein inside that. Artery lies lateral to the vein. Then further medial to the vein, here there is an open passage which is called femoral canal, and inside this femoral canal there are lymphatics and the upper end of deep inguinal lymph nodes. Now the femoral nerve actually lies lateral to the femoral sheath. It is not included inside the femoral sheath. Remember this fact. And we also said that the fat lying between the transversalis fascia and the peritoneum, which is called extraperitoneal fat, actually forms a septum at the opening of the femoral canal at the area called femoral ring. Now this area is called the femoral ring, and that femoral ring is actually protected by this the thickened extraperitoneal fat, which is called femoral septum. Now you can develop hernias, which are called femoral hernias, coming out through this femoral canal, and when the hernias are formed, they actually push this femoral septum in front of them. Now, I previously said that this femoral canal contains some deep inguinal lymph nodes, and these deep inguinal lymph nodes are called nodes of Cloquet, and they drain the glands penis in males and clitoris in females. Now remember this point. Sometimes this point is checked in examinations. And this slide actually shows the relationship of the femoral nerve to the femoral sheath. It lies lateral to the femoral sheath. It does not lie inside the femoral sheath. Remember this fact. Then we talked about the opening of the femoral canal, upper opening of the femoral canal. We said it is called femoral ring, and in this slide you can see the inguinal ligament in this and this purple colored, pink colored line, and behind this is actually the, the, the pectoneal ligament, and this this is actually the femoral ring, and this is actually the femoral ring. Okay, this part is the femoral ring, and if you look at the boundaries of the femoral ring, the femoral vein lies lateral to it. Actually, there is a septum between the femoral vein and the. Now the point is, if you take the femoral sheath, this whole thing, there are two septa inside that, dividing it into three compartments. In the lateral compartment, you get the femoral artery. In the middle compartment, you get the femoral vein, and in the medial compartment, actually, you get the femoral canal. Now, when it comes to the boundaries of the femoral ring, actually, the lateral boundary is the femoral vein and the septum lying medial to the femoral vein here, and the posterior boundary is the pectoneal ligament, and anterior boundary is the medial end of the inguinal ligament, and medially it is the sharp, free edge of the lacunar ligament. These are the boundaries of the femoral ring. As I said before, the structures here in the abdomen can actually pass through this femoral ring, and then it is called femoral hernia. Okay, so this is lacunar ligament actually, and this is the femoral ring with its boundaries. Oh, the femoral hernia, even though you have not done inguinal hernias, you have not done the abdomen yet, but remember this point, you can easily differentiate between femoral hernias and inguinal hernias by going by the fact that femoral hernias lie lateral and below the pubic tubercle, which you can feel in the patient's body, pubic tubercle, and the inguinal hernias, they lie medial and above the pubic tubercle. Femoral hernias lie below and lateral. Inguinal hernias lie above and medial to the pubic tubercle. Now we discussed the inguinal lymph nodes in detail during the last lecture, so I will just rapidly go through it. Inguinal lymph nodes, we divide them into superficial inguinal lymph nodes and deep inguinal lymph nodes, and the superficial group of inguinal lymph nodes can be further divided into a vertical group lying along the great saphenous vein, and a horizontal group lying immediately below the inguinal ligament parallel to it. And remember, all the superficial inguinal nodes lie superficial to the fascia lata in the subcutaneous tissue, and deep lymph nodes, they lie deep to fascia lata. Now if you take the horizontal group of superficial inguinal nodes, there is a lateral group and a medial group. Now the lateral group and the deep inguinal nodes, they lie along the medial aspect of the femoral vein, and some are in the adductor canal, then some are in the femoral triangle, and the upper end of these deep lymph nodes, they lie inside the femoral canal, and they are the ones that are called nodes of Cloquet, and they are the ones that drain the glands pleuris and clitoris in females. And when it comes to the areas of drainage, deep inguinal nodes, they drain all deeply from the lower limb, including the popliteal nodes, and at the upper end, as I said before, glands pleuris and clitoris, and superficial inguinal nodes also ultimately drain into deep inguinal